We are excited to be able to do a version on pediatric vascular surgery. And so with that, I'll turn it over and we'll let our team get started.
All right. Thank you so much, Misty, for the opportunity to present, to help MC, I should say. So I'm Lindsay Krepta. I'm from the Medical University of South Carolina. I'm part of the Young Surgeons section of the JVS, and so I'm happy to be here. Tonight we have two exciting papers on pediatric vascular trauma. So one will be the interdisciplinary vascular reconstructive considerations for pediatric tumors. The second will be blunt brachial artery injury in pediatric patients. And let's see here. Sorry. No, it's not advancing.
The technical difficulties just keep on coming.
No, I'm so sorry. There we go. Okay, so first we'll start out with Dr. Alex Fairman. He's going to be giving us an overview of pediatric vascular injuries, and then we'll have a critical appraisal of our first paper by Dr. James Kelly. This will be followed by some discussion from our authors, including Dr. Mohammed Said Hafiz, as well as Dr. Mohammed Islami. Some of our other authors that have joined us are going to be Dr. Alyssa Stetson, as well as Dr. Raghu Montanagli. And finally, thank you to our special guests who will be here as well discussing the papers, and that's going to be Dr. Catherine McGinnigal and Dr. Jeffrey Syracuse. So just in way of reminding everybody, please stay muted during all of this. Submit your questions or comments in the chat if you could. The moderator may call on you to answer the questions, and the event is being recorded for on-demand access as well. Please join us for the next JVS Online Journal Club, which is going to be a clinical practice guidelines for blunt thoracic aortic injury topic, and that's going to take place on Wednesday, July 8th at 6 p.m. Central Time again hosted by the Young Surgeons section. Registration for all upcoming Journal Club events is also open at vascular.org. All right, so I'd like to get going for tonight, and I'm going to ask Dr. Alex Fairman to take over with sharing his screen.
Can you hear me okay?
We can.
Perfect. I'm going to try to bring up one thing here, and it's just loading. My screen sharing is loading right now. Let's see. Is it being shared?
Not yet.
Let's try this.
That's not a very good trick. It didn't work.
Hmm. Well, I was going to share the QR code, but it's still loading for me, but
I'll put the QR code in the chat. How about that?
that's perfect. Thank you. That's all I was really going to share.
I can do
But
that.
But thanks for having me on here. I'm subbing in for Dr. Coleman. By way of just a brief introduction, my name's Alex Fairman. I'm a vascular surgeon at the University of Pennsylvania. I'm also the director of pediatric vascular surgery at CHOP, the Children's Hospital in Philadelphia. I'm just going to give a very brief overview of what it means to treat patients with pediatric vascular pathologies, and what it means in my practice and what it may mean in others, and that might be slightly different. So I'm a full-time adult vascular surgeon, but I also have a full-time separate practice at the Children's Hospital next door, and I recognize that's a unique setup in a lot of cases. But in general, patients with pediatric vascular pathologies really span a variety of disease processes, and I think that's important for a lot of people to understand and know, from traumatic vascular injuries to aortopathies, to vascular malformations, oncovascular case involvement, hemodialysis involvement, and many others. And so, just to give you a quick flavor of my practice, I do about 100 cases a year at the Children's Hospital. Almost 98% of them are actually elective. And again, I do a lot of different things. Mostly what I do are elective cases involving either aortopathy patients, so patients with mid-aortic syndrome and renal artery stenosis, and then kids with just random arteriopathies and aneurysmal disease. and I have a very busy thoracic outlet practice at the pediatric hospital, and the rest is just really a potpourri of mixed pathologies you would also see on the adult side. So a very broad practice. And in my practice in particular, I actually don't do a lot of traumatic injuries, but that's also a very important component of patients with pediatric pathologies. It's a very underrepresented subset of patients, and I think a lot of people who are adult vascular surgeons, for example, are very fearful of treating kids in many instances. And hopefully, through discussions tonight and um, other discussions that have been set forth by the SVS section that myself, Dr. Coleman, and others are involved in, which is a multidisciplinary section in the SVS of pediatric surgeons and vascular surgeons, we can shed some light on how to best manage this very challenging patient cohort and also stimulate interest across multiple specialties so that these kids can get the best care possible. And I think Dr. Humphreys has shared this APDVS survey that Dr. Coleman has spearheaded, which is really a survey to understand and guide how our trainees, particularly in vascular surgery, get experience with the pediatric population. One of the challenging things, obviously, about training in vascular surgery is not all of us will get a lot of pediatric vascular surgery exposure. So I think it'll be important to understand how this varies across the country, and how much involvement our trainees really get. And that's important to really elevate management of this patient population. So that's all I really have as a brief introduction, obviously throughout the meeting, and now I'm happy to answer questions.
I think as questions come up, we can hopefully direct those to you, especially as we're going through the papers. And so why don't we go ahead and switch over and we'll have the University of Toronto get us started.
Jamie, are you getting your slides up?
Yep.
Dr. Kelly is one of our new recruits. He trained in the UK and came over to do a fellowship in aortic surgery with us at the University of Toronto. And with that, it's actually quite fitting because the hospital that he will be working at actually does combine oncologic cases with mostly adults, but also covers our children's hospital. So definitely he's had exposure with both trauma as well as tumor in both the pediatric and adult population from a vascular reconstructive point of view.
Thank you very much. Hopefully everyone can see my slides. Fantastic. Thank you very much for the opportunity to speak and to talk about this topic, which I've been lucky to have some experience in particularly an adult cohort, but yeah, it was very interesting to talk about and to read this paper, which we all read, but in something which was fairly alien to me, and interdisciplinary vascular reconstructive considerations for the pediatric tumors. So very briefly, with regards to the background, this paper synthesized the considerations that go into play when a vascular reconstruction in kids is undertaken, when there is a solid tumor, which may or may not involve major vessels. Thankfully, these cases are rare, but I'm going to highlight that point because actually that's one of the most important points of the talk, because by being so rare, that means that guidelines are quite difficult to create. It means evidence is quite difficult to create. And ultimately, it means that training has implications too. So I've touched upon some of those unique challenges, which I think are important to lay the foundation before we go into analyzing the paper. There are other challenges to children which are different to adults. Of course, we have the unique challenge in these children where these vessels, of course, need to continue to grow. These limbs need to continue to grow. There's a risk of differences in limb length. And of course, as I've touched upon there, limited cases means limited training. What are the implications for the next generation? So moving back to the focus on this paper, as a study type, it's a narrative review. And then the most important question, is that appropriate? Well, I would argue that actually in this scenario, it is probably appropriate. These are rare cases which are undertaken in a relatively infrequent manner. And the paper summarizes some of the surgical techniques, but goes beyond just the surgery. It talks about the thinking behind chemotherapy, the management across different tumor types. And with regards to the registry that was created, there's a very good table which is provided early on in the paper, which summarizes the 24 studies that they include. With regards to the study periods, these are ranging between these 24 studies. The earliest I noted was went all the way back to 1981, and I noticed that the most recent was from as recent as just a few years ago. And with regards to the follow-up, I noticed there's one paper by Mayer et al. Had a follow-up of actually over 30 years, but I calculated that most had a median of around 4. With regards to outcomes, there was quite a significant amount of heterogeneity in that. Only 8 of the 24 studies actually reported on vascular-specific outcomes, and most papers, or almost every paper, commented on largely major morbidity and mortality outcomes. With regards to exclusions, there was no clearly defined exclusion criteria. Most of these were retrospective case series, understandably, in institutional records, and therefore a slight heterogeneity again with the patient selection. With regards to the study cohort, across these 24 different papers, I calculated that there was a total of just shy of 2,000 children across 8 different oncological diagnoses. And as we've mentioned, this is a narrative review rather than an original research study. And as we touched upon, these are largely case series, expert opinions, and cohort studies from these very unique, challenging pediatric patients with solid tumors that may or may not have vascular involvement. This wasn't actually included in the paper, but I thought it was quite nice to create. It talks about, I wanted to summarize how many different studies were included in the paper between the different solid pediatric tumors and how many of those actually had vascular involvement. So with regards to whether this is a generalizable cohort, that's a challenging question to answer. To most of us, we have very limited, if any, experience with such cases. But to someone who may work in a place which may have such cases, then yes, actually, I would say that in that unique scenario for that unique vascular surgeon, then this would be potentially. Inevitably, there is heterogeneity, not just in the age of the children, where the studies varied a little bit, not just in the diagnosis and the malignancy and the aggression of the histology, but also whether there was or wasn't vascular involvement. And with regards to selection bias, I would say that there was definitely some degree of selection bias with some papers only describing surgical cases, the Sheehan paper I noted, but others were talking about all comers, not just surgical people that they didn't operate on and people that may have just had other non-surgical interventions. I'm not going to go into this because this is, we've all read the paper and ultimately it's beyond the scope of critically analyzing the paper, but I would like to say that the paper is structured in a very nice way for the reader to be able to go through in a systematic manner for a readership who would likely have very little exposure to such things like Wilms tumors and so on. And it did talk about things that, frankly, I have to be honest, I didn't know about the Down classification, for example. I did think it was presented in a very succinct manner, which was quite easy and digestible for the reader. Going back to the critical appraisal of the paper, with regards to statistics, there was a limited statistical analysis, and even the authors themselves state that it wasn't fully applicable because it was a narrative review rather than an original research study. And inevitably, much of the data that was provided was very much descriptive, be that the patient numbers, the survival, the complications that were encountered, but also some of the vascular specific outcomes such as graft patency, which was mentioned, as I say, in 8 of the 24 different papers. It should be worth noting that there was no formal meta-analysis that was performed. There was no pooled quantitative analysis, and with that, confidence intervals, p-values, and any assessment for heterogeneity, understandably, wasn't provided. So what are the strengths with this paper? I would argue that it was a very unique paper. It was a very good paper, clearly written by people who have tremendous experience within the field, which actually in total nearly includes up to 2,000 children with these very rare malignancies. So it's very unique on that front, many of whom had vascular involvement in addition to the solid tumor. I think the strength of the paper particularly is that really harnesses the importance of the multidisciplinary approach in these pediatric cases, and the unique challenges offered, not just from a surgical or a vascular perspective, but from an oncological perspective, and it also touches upon important transplant principles. I think it's worth mentioning that the table at the beginning was very, very nicely done. It was very digestible. It was very easy to read and understandable to see what was included and what the follow-ups were for each of these different respective studies. And it should also be commended upon that there was a very clear conveying of what the graft surveillances, patencies, and growth-related complications are, which are entirely unique to this cohort of children with vascular with solid tumors that may have vascular involvement. Some of these limitations we have touched upon. There was no systematic search strategy that was provided, and I think I have to use the word inevitably, but inevitably they are dependent on small cases or case series done by experts thankfully infrequently, but the problem with being infrequent is that ultimately that leads to difficulty in presenting cases such as this. Inevitably, there was heterogeneity amongst the tumor type and amongst how these different tumors were then managed, whether they were managed operatively with neoadjuvant chemotherapy and so on and so forth. Only 8 of the 24 papers that were included a description about vascular-specific outcome reporting. And as we touched upon, there was no pooled statistical analyses. So as a verdict, what can the paper tell us? I would say it was a unique paper that has a very important and clinically relevant review of what is a rare area of vascular surgery. The major strengths are the stress on the importance of the MDT. There's a very practical surgical focus reflecting real life practice. And I think it does make a very good attempt at synthesizing the available literature which is available. What the paper can't tell us, of course, it is dependent on low case series and expert reports of what are rare pediatric oncovascular conditions. And of course, this is not an easy area to create RCTs or large prospective studies. Of course, we can appreciate that. And there was an inevitable challenge regarding the heterogeneity of the data. What I would argue the take-home message is that these are unique cases. They are very challenging individual patients that also, of course, have a unique dynamic from the input of the parents. That it discusses the how to consider not just the tumor and the histology and the extent of the disease, but the differing surgical and non-surgical options, as we touched upon with neoadjuvant chemotherapy, and also even some of the individual papers did talk about children that were actually palliated in one paper. It also stresses the importance with regards to a vascular perspective of long-term surveillance to ensure that the organ and the perfusion of limbs in the long term is preserved, and that these are, of course, young people that we're operating on, and the importance of a very long-term follow-up of these uniquely challenging patients. And so does this change the practice of a standard vascular surgeon? Well, on the largely, probably not, because this is only done by a very select cohort of vascular surgeons. But I do believe that the paper conveys a very important message and does very nicely and succinctly convey the complexity of these cases, the complexity and the challenge in managing these patients when they don't have strict guidelines to adhere to, and of course the importance to manage these children in specialist pediatric surgery units. Thank you very much.
Thank you so much, Dr. Kelly, for that overview. I'd like to open it up to the authors that have joined us tonight. Dr. Stetson, Dr. Matagnahali, if you'd like to go ahead and share your screen or take over the discussion.
Oh, I don't have any slides. I was told not to make any slides. That was easy for me. So I don't know whether if Alyssa is online or not. If Alyssa is online, I think she did the bulk of the work. I think as a vascular surgeon, my responsibility was collaborative and helping our pediatric surgery colleagues to put up the manuscript together. I mean, obviously, this is a manuscript through the APSA as well as through the SVS collaborative efforts. We were asked to discuss about the oncovascular reconstructions in the pediatric population. As James did a wonderful job, I think he took much of my conversation points. I think the last slide basically summarizes everything what I wanted to say, including the fact that I think this is supposed to be a narrative paper exclusively for the audience, especially for vascular surgeons. Most of them, they may not be privy to the happenings in the pediatric oncovascular reconstruction. As you rightly pointed out, this is a very selective subgroup of patients, even for the pediatric surgeon who are going through the conducting the resection. Those patients requiring a vascular reconstruction is even much, much more smaller. So, but one thing is certain, I think reading through the literature as well as crafting this manuscript, obviously things that stand out is pediatric populations are very unique. We all appreciate that. I think the tumor biology is completely different. The response to the chemotherapy as well as to the resections are entirely different. Obviously, trying to get a curative resection is going to be ideal, but at times it may not be possible because of the vascular involvement. I think this is where the vascular surgery specialty steps in. Not many people do the pediatric vascular reconstruction, barring some academic centers wherein we are affiliated to large pediatric hospitals. Clearly, I was asked to talk about four specific items. One would be the gap. The gap, what actually led to this manuscript or arriving at this paper was there is a lack of knowledge, there is lack of awareness, there is lack of substantive review, in this specific area. And this was one of the singular effort to get all of those data points pulled into one article, which can be used by our vascular surgery colleagues as a reference guide initially. Clearly, the purpose of this paper was not to provide you any statistical detailed analysis, as well as the meta-analysis was not the purpose at all. There is so much heterogeneity in the tumor biology, the age of the patients, as well as the chemotherapy role that is involved, as much as the choice of conduit, if you want to think about it. So there is a lot of factors that actually differ, which would limit the ability to conduct a meaningful statistical analysis comparing head to head with the treatment plans, basically. So what actually came out as a surprise for all of us from the exercise was how limited the data is. There is not much data. As you rightly said, there are only about the manuscript captures the entire table set of the published articles wherein there was vascular involvement with the major solid intra-abdominal tumors as well as the soft tissue sarcomas. There is very limited data set, and even with that, we have very limited amount of vascular involvement. Clearly, we are not able to capture every bit of the outcomes because the outcome reporting itself is not standardized. I think this is where I think we have the opportunity going forward to address Misty's question, what next beyond this paper? Beyond this paper is basically trying to continue to have that collaborative effort. Whether it's the regional societies or the national societies should be able to come up with a registry. I'm sure the pediatric surgery has a registry, but I think how much data points are imputed into that data set is going to be something we should look at it, and also take an lead on this collaborative data points being pulled in and eventually translating into a much more meaningful results for our patients. I think I would stop at that. I don't think I have anything else to add on besides what has been said by James. He did a wonderful job in summating the entire paper. Thank you, James. And also, if Alisa is on, please speak up. I tried to reach Dr. Greg Tiao. He's the senior co-author. He was from the University of Cincinnati program, but since the publication, he actually left to a different program. I'm unable to connect with him, and unfortunately, I was not able to communicate that. Thank you.
Raghu or James, could you comment a little more on conduit?
Sure. This is a very challenging question, Jeff. There is one thing is certain. I think if the depending on the age of the child, sometimes the choice of the conduit is also selected. I think if the child has reached sort of a late teens, a prosthetic material where there is no expected contamination with the bowel is expected, then I think we are safe enough to say you can use the some sort of a prosthetic material, whether it is a Dacron or a PTFE, knowing very well that these children will be requiring some form of additional corrective surgery at a later date. Um, when you anticipate a contamination with a urinary tract or uh, with the intraperitoneal ball contamination, it's equally safe to say use a biological conduit of some nature. At least in my practice, I have used cryografts, more so of a fempop arteries more often in circumstances where there is a need for a bowel resection, where there is a concern for a leak at some point of time. I would lean on the use of biological conduit in those patients, knowing very well that the patency is not going to be great in the long term, and knowing very well that we adapt to certain described historical techniques, especially using the interrupted anastomosis. Um, you know, Even though we factor that, still, there is no clear-cut guidelines on recommendations regarding what conduit has to be used under what circumstances. Um, I don't know. I answered your question. Probably it opens up to more questions for all of us.
No, I think that's the basic everybody's answer. We don't really know.
Yeah.
I was hoping you'd help me out.
I rely on a lot of deep vein and aquavascular reconstructions, especially in younger kids. I have no hesitation using deep vein, and would really struggle to put in prosthetic in a younger kid.
Yeah.
What
I
deep
think
vein,
that,
Alex? Are you using like their own femoral vein? Using cryofemoral vein? Like what are you using?
No, I try to stay away from cryo as much as possible. I use their own deep femoral vein.
I think I agree with Alex's point. That is a default option for us as well. I think we definitely use a lot more of deep femoral vein, but depending on the caliber of the structure, then you may have to make a inevitable decision at times, and that decision is basically knowing very well that you don't have a good choice. You don't want to put a prosthetic material. You don't have a good deep venous choice, so then you're obligated to do a reconstruction with some form of cryo. I've seen that more often with the patients with retroperitoneal sarcomas, especially with either a rhabdomyosarcoma or a major tumor, wherein there is involvement of the pelvic veins, or for that matter, having deep venous thrombosis in the lower extremities as a result of the compression, then you just have no good choices there. Yeah. Is Alyssa online? I don't know that don't see her.
I had another quick question for you. I was wondering, do you have any idea, sort of in your review of the literature, how many of these vascular reconstructions are being done by vascular surgeons versus the pediatric surgeons? Because at least at our institution, we get asked by the adult surgeons a lot to help with these, but really not very often with the pediatric surgeons. And I assume the reconstructions are being done mostly probably by themselves. So I was just curious.
Sure. I think the based on the article, I can't actually say. Maybe we got to go back and look at it. I think if the primarily all the authors have been pediatric surgeons, then I would assume it's more likely written by the done by the pediatric surgeons. But where there is a collaborative vascular surgeon, then I got to assume there is a vascular surgery component in that. That's one way of figuring it out. But I have not done that point. But I also say that the transplant surgeons may be helping them too. To some extent, I think, there are pediatric transplant programs, across the country who may feel comfortable in dealing with some of the portal vein reconstructions or the hepatic artery reconstruction, or for that matter, doing some aortic or vena cava reconstruction. They probably done by the transplant surgery teams as well. Yeah.
And I think a lot of plastic surgeons in the pediatric world do a lot of reconstructions, especially micro reconstructions too.
Looks like there is another question in the chat from Dr. Kelly. Would you ever consider arterial/radial conduit?
Well, the choice of the size match, I think that ultimately it all comes down to getting an appropriate size match, isn't it? I think there is definitely some data supporting that, small children, especially if they are weighing less than about 12 kilograms, their outcomes following a vascular reconstructions are not that great. They're prone for vasospasm, small caliber arteries. You're going to risk some of that challenge with the using a radial conduit. However, as Alex mentioned earlier, if you have a small segment that you require, and if you're using a hypogastric artery, that is reasonable conduit. But I think the radial conduit, I'm not sure about using it in a lower extremity. Unless and until it's a very small tibial artery reconstruction, something of that nature, then I don't really see a reason for that. Well, Misty, thank you for the invitation and thank you for taking part in this, allowing us to, showcasing our work. I'll tell you, I think it's appreciated.
Absolutely.
Yeah, James did a
Sorry,
wonderful job. Yeah.
the dogs are barking, and so I couldn't get myself off mute and kind of coordinate all of this. So, Dr. Corpetta, do you want to go ahead and move to the next one?
Sure.
I can say, sorry, like I am here. This is Kate McGinnigal. My camera is not on because every time I turned it on, my Zoom crashed and I got kicked out of the meeting. So, I had some comments as like the moderator of this, although Raghu, obviously you do not need moderation. But if it's useful at all, I have a couple of questions related to, peds vascular reconstruction in general. I do almost all of the cancer reconstructions at UNC, including for the children. And I think that the point that's maybe the most important is knowing ahead of time if an R0 resection is really worth it. And you touched upon this, especially in the Wilms tumor section of the paper. But, I sit together with our pediatric surgical oncologist, before we even get to the operating room to figure out like what is the best outcome. Obviously, that's an R0 resection that doesn't require any vascular reconstruction. And then what's an acceptable outcome? Like, is it really more important to get an R0, even if that means we take vessel and have to replace it? Or is it better to leave a little rind of tumor on the vessels and avoid reconstruction? And, obviously based on the tumor types, they have many, many guidelines about that. And so I use that to help me understand how to help them. And I realized as I've gotten to do more and more of these, oftentimes I do that as a co-surgeon case with the expectation that I'm not going to be replacing any blood vessels, but I'm just going to be helping expedite the whole dissection and make those decisions for the really big, really hard tumors. We make 3D models sometimes from the CT scans to kind of help with orientation and figuring that stuff out too, which is something that the adult cancer surgeons definitely don't do. And it's pretty cool. I do think that as a next step, that I love that APSA and SVS is, getting together. There's also the Pediatric Surgical Oncology Research Collaborative, which is basically like very low disease frequency consortium for us. And I asked one of my partners in the Children's Hospital is part of that. And I asked her if any vascular surgeons had like weighed in on what variables go into their registries. And as far as she knew, that we hadn't. And so some of the things that we are really curious about conduit, or who needs anticoagulation afterwards, or in the adult literature, there's emerging data on low-dose DOACs after cancer reconstructions. Where does that play a role? Like, these are the things that we need to know about that they're not collecting, but they do have extremely robust registries for all of their tumor types. And being able to contribute to that, I think, would be a really, really important and impactful next step. If you're not already working on it, Dr. Fairman.
Yeah, I completely agree, Catherine. You know, anticoagulation is something that we struggle equally with. How long you're going to continue, um, the type of anticoagulation, the dose, the duration, everything makes an impact. There is absolutely no doubt. I think we touched very briefly in our manuscript, knowing very well that there is paucity of data pertaining to that element. But again, these registries are a fertile ground for us to continue to get better data, or look at the question in a different angle, and hopefully we will be able to arrive at better treatment plans for the patients in future.
Yeah, absolutely.
All right, perfect. If there are no other questions, I'd like to move on to the second paper, if that's okay. I'm going to go ahead and share my screen. I apologize. I don't know what is up with this link today. All right, here we go. Okay. All right. So I'm going to present the second paper on behalf of the Pediatric Vascular Surgery Task Force. So that's the blunt brachial artery injury in pediatric patients.
Lindsay, I'm going to have you go up to display settings and swap your displays where the little caret says display settings. If you click on on your screen on the little arrow next to it, it will then, because we see your presenter mode.
Defaults to that for some strange reason. That didn't help it, did it?
No, again, if you just go to display settings and hit that little arrow right next to it,
Yeah.
it should say swap screens, and then you can just flip it.
It comes up and it says share screen. Try to fix it another way. Sorry. I have multiple computers here. Okay. All right, share settings. Oh boy, it's still not doing it.
Can you see the presenter mode where it has the two slides?
Yeah.
Yeah, and so right up there at the top of that, you can just swap the screens if that's easier for you.
Sorry for the technical difficulties here. All right, I'm guessing it's not doing it, is it?
Not right now, no.
Can you see anything on my screen?
We cannot.
All right, let me try one more way here. Oh, Zoom. Okay, how about now?
Perfect.
Okay, all right, I am so sorry. All right, so blunt brachial artery injury. So less than 1% of pediatric trauma involves vascular surgery injury, with the most common anatomical site of pediatric vascular injury being the upper extremity. So it's still only 34.9% of all pediatric vascular injuries, so it's still not very common. So most of the data that has been published has been extrapolated from adult vascular trauma due to this low frequency. So in 2021, the SVS partnered with the American Pediatric Surgical Association to establish a task force which was dedicated to optimizing pediatric vascular care through a multidisciplinary educational approach. So this paper came out of this task force, and the aim was to review the current and multidisciplinary literature to summarize the pathophysiology, the clinical presentation, the diagnosis, evaluation, and the best management of blunt brachial artery injury. So here they show the studies that they were included. So it's really not that many studies. You can see the different number of subjects range from only 11 to 336. So this was a retrospective literature review, and it was just of pediatric patients. And again, they didn't have any exclusion criteria for their published paper here, but as you can see that most of them did involve complex supracondylar fractures, so that's sort of where they focused on. So the most common cause of blunt brachial artery injury is the supracondylar subluxation, and that's usually when a child falls on an outstretched hand. So I've only seen this twice in my current practice, but I like to call it the monkey bars injury because both times it was somebody swinging from the monkey bars and landed on their hand. So the different etiologies can range from, causation of spasm to mild endothelial injury to complete vessel disruption. And then some of the other etiologies or mechanisms that they were talking about in their review were bicycle injuries, as well as high-speed motor vehicle crashes and even crush injuries. So here is their figure 1. It's really their treatment algorithm, and it's kind of a summation of the majority of the paper. So it's very easy to digest. It's very easy to follow. So we'll kind of go through it piece by piece, but there is the algorithm in its entirety, if you will. So they do advocate for increased suspicion for blunt brachial injury whenever you have a child that's presenting with diminished or absent pulses in the affected arm with a normal contralateral arm. Neurodeficits and cold upper extremity in the setting of a dislocated ipsilateral elbow, again, would be a clue to start thinking about blunt brachial artery injury. And the modalities that were used in the majority of the papers were Doppler exam, upper extremity, pressure indexes, arterial duplex ultrasounds, and if those were not available, then CTAs of the upper extremity. And lastly, they do talk about intraoperative angiograms, but the authors recommend it as a last resort due to vasospasm in the pediatric population, as well as an increased risk of complications. So sort of their summation for management is ultimately keeping the child warm, no more tensive and pain-free is the most important thing. Controlling hemorrhage, there isn't always a lot of hemorrhage with these injuries. If there is, there is literature about tourniquet access, or if necessary, you can place a tourniquet, and they always advocate for a multidisciplinary approach. So the first step in management, so they coined this term, and again, it might be something that is out there, but I'm not familiar with it until this paper, a pink pulseless hand, or a PPH, as they call it kind of throughout the paper. So first, if you have a pink pulseless hand, you want to stabilize the injured elbow by having ortho see the patient. And then they went into their literature review, kind of looking at when can we observe these versus when should we take them to the OR for exploration, which is kind of the natural question that I think all of us have when we see these patients in the ED. So some of the systematic reviews, and it was really only 2 of them, but they were 2 of the more contemporary reviews, concluded that close observation and secondary surgical exploration is only needed if the neurovascular exam is worsened. So the authors liked these 2 papers. They say they're slightly more contemporary. They're from one of the trauma big databases, so they had slightly more patients involved in these, versus they do cite that there's some other older studies with smaller subjects in them total that do advocate for surgical exploration. So this led the authors to conclude that conservative expectant management should be the initial approach to these patients with arterial exploration only for ischemic changes. So further recommendations when they went through the literature is aspirin if no contraindications, and then if there are limited injuries like contained flaps or dissections, which again I think is kind of a gray area, they do recommend if there's no apparent ischemia, they can be managed with anticoagulation alone. So again, these could be those pink pulseless hands. So surgical repair, if you do decide to take the patient for surgical repair, the obvious choices are primary repair, vein patch repair, interposition graft with autologous vein. And again, they do advocate for avoiding prosthetics due to infection, size mismatch, and growth potential, which we talked about in our last discussion of the last paper. So for the exact same reasons, they also mention the thought of maybe using a temporary vascular shunt. Some of those were included in some of the reviews that they looked through, and they seem to advocate for them if you have to delay your reconstruction, either because of time taken to get deep vein out or management of other life-threatening injuries or need for reduction of the extremity first before revascularization. So the anastomoses, they talk about doing interrupted suture. Thought it was interesting in the first paper, they acknowledge that there's really not a lot of literature that talks about interrupted versus continuous suture line, but the thought would be interrupted allows for vessel growth with the child, using some of the micro techniques from our plastic surgery colleagues, such as interrupted 7-0 or 8-0 Prolian sutures. They acknowledge complications. They don't talk about a lot of the percentages of arterial thrombosis or vasospasm. They don't give a lot of kind of outcomes in general with their review. They do talk about, again, kind of just acknowledging endovascular therapy is out there. There's only a couple of case reports, so they would recommend really using it as a bridge but not definitive repair. And again, advocating for lifelong surveillance, which was justified in a couple of their papers that they referenced. So the verdict. So the conclusion of their paper was many patients with pink pulseless hands can be managed conservatively after reduction of any associated dislocation or fracture. However, if distal perfusion of the hand is not ensured, so it's a white, cold hand, then arterial exploration and repair are indicated. So I thought this was actually an incredibly easy to read paper. I thought they synthesized the material maybe a little bit too well sometimes, but I thought it was done really cleanly. It was easy to read. The figures were nice. I thought that the table was very nice and the flow sheet is very easy to follow. So, ultimately I would definitely, reference this in my practice going forward. I would recommend it to colleagues. I guess my only question that I had when I deal with these injuries, at least, is that sometimes there is associated nerve injury, and they didn't touch on that at all, and that can really complicate when you have some of these ischemic changes. Is it from nerve injury, or is it from actual ischemia? So I guess that would be sort of my question to the authors. And that's all I have, so I'd just like to open it up to the authors that we have with us here today. If they would like to take over now. I think we have Dr. Islami I saw, and then Dr. Saeed Hafiz as well.
Hi. Thank you, Lindsay, for such a great review of our paper. I think the only thing we wish we could have included more was more vascular long-term outcomes, as those tend to be limited even in the reported literature. And moreover, when it comes to nerve injuries, perhaps Dr. Islami can add a little bit more over there, what his practice has been.
Hafiz obviously did all the heavy lifting. He actually had a nice presentation. But thank you for your comments about the writing and all that. That's basically he's doing, Dr. Hafiz doing. But I mean, this was the paper that was coming up from that work group, and the reason behind it was that this is actually a type of injury that most vascular surgeons end up seeing in their practice. I have had the misfortune of dealing with 3 or 4 of these, and most of the time actually ended up using a shunt, which is basically an Argyle shunt that I have been carrying in my bag for the past few years, because at one institution they didn't have it. We had to use a neonatal feeding tube that they happen to have. So as far as the injury to the nerves, I have to say I'm not sure if I've seen one that needs to be dealt with, but if there is, this is something that the plastic gets involved with it, and of course they're much better than we are in dealing with it. And the question about the aspirin, I think there was one question about use of aspirin. Yeah, I'm not sure if, again, this is a protocol based or whatnot. If the injury to the artery is not severe and they do well, we just put them back on the aspirin after that. But especially with the pulseless pink pulseless hand. Who does these repairs? Yeah, so I have actually done one of those of the three that I've dealt with. The two, we actually asked the plastic to come in because the artery was very small, so we harvested the vein, gave it to them, and they actually use a microscope, and they use very small sutures and all that. But again, if it's a reasonable, more than 7 or 8 year old kid, I think a vascular surgeon can easily do it.
Mo, or I guess to say, are you who gets a patch versus a bypass? That's what if I comes in tonight and they need something done, who am I patching, who am I bypassing? What do you think? Because this is for blunt trauma in general, which comes up sometimes. Can I get away with the patch or not? Or need to get the vein to the bypass? So what do you think about this, especially for kids?
I think if it's a little bit of a judgment thing that you figure it in the operating room, and you can basically eyeball the artery. If the artery is badly damaged, you can actually, in kids, you can actually remove a segment of it and put it end to end. But if the injury is to a portion of the vessel, then maybe it's reasonable to open it up and put a patch on it. And I did it for a different case, and it works actually pretty well. You can just get a piece of vein and just use it as a patch. That kid had a pseudoaneurysm after IV placement. But so I don't know exactly because again the numbers are very small. So I don't know if it's going to be a earth-shattering recommendation, but I would just eyeball it. And if the injury to the vessel is not very severe, I'll probably patch it.
What about harvesting leg vein for the patch, or what if you use a bone pericardium? Is that on the table?
No, it's much better to use the vein of the kid for the same reason that the vein is going to grow as well as the bovine pericardium, which is going to be a stiff piece of material. So the vein has the capacity, if it stays alive, to kind of grow with it. And the recommendation to do interrupted versus running suture was basically for that reason, that the vein grows both axially and also at the width. So you want to accommodate both of them.
Any other questions in the chat? Is there anyone I guess, is there anyone you're giving, Lovenox for versus aspirin? Like, is you have algorithm for that you would think?
Again, most of these things were basically our opinions, not necessarily based on any concrete data or anything like that. I have a feeling putting a kid on a DOAC may cause some other problems. So aspirin would be much more gentler unless they have some issue with the aspirin. Lifelong aspirin, I don't really know if there is any data for that, but most of the patients we do bypass on, they go on lifelong aspirin, so maybe.
One of the most challenging parts of these is the vasospasm you get after these injuries. So, do you want to talk a little bit about what your strategies are intra-op and post-op after your repair? Do you put them on a little bit of low-dose heparin after you do more challenging repairs, etc.?
Yeah, the small one that we did with the plastic, we actually put them on what we kind of describe a chicken heparin. So you don't need it to be reaching a magic number. You make sure that they stay warm. It's very important that they remain euvolemic because if they're not, they can go into spasm. So you make all the efforts to make the spasm out of it. But admittedly, you know, obviously, if you do enough of these, you may have a situation that they go into spasm right in front of your eyes. As a personal note, the longest case I've ever done in my life was on a 15-year-old kid, a popliteal knee, posterior knee popliteal repair, and that took me 15 hours because every time we put the artery together, it went into a spasm and we had to open it up and all this stuff. So it's important to keep them warm. It keeps keep the pain under control and keep them euvolemic and some chicken dose heparin.
All right, I think that's done with this paper, and I'll give it back to Dr. Krebda and Humphreys.
Thank you very much.
Great. Well, thank you so much. I think that that was a really interesting discussion, especially because it is such a gray area in the literature, and thankfully we don't see it very often. But when we do, it is difficult to distinguish that spasm versus arterial injury. So I appreciate any recommendations that you have, and I appreciate everyone's time tonight. If there's no other questions, I'd just like to draw your attention to the QR code again so we can get as many people to complete the survey as possible. And I will conclude here and let Dr. Humphreys close if she has any closing remarks.
Yeah, well, don't forget that we'll be back in July. I think we're going to have a really great discussion about the new blunt aortic guidelines that have come out in March for from the SVS. And so I think there'll be a lot of good discussion. We'll have Joe DeBose and Ali Azizadeh at that event to talk about those and give us some guidelines or give us some guidance on what we should be doing with blunt aortic injuries. But tonight I learned a lot about what I should and shouldn't be doing with pediatric vessels. I learned that it's okay that it spasms and it freaks me out, and then I just keep going, even if it's been 15 hours. I'll call you up, Mo, and I'll be like, I need a pep talk, and maybe you can help me at that point. So. But thanks again to our authors and to Dr. Fairman for being here. And of course, our moderators, Dr. Syracuse and Dr. McGinnigill. We'll see you all in July. And hopefully we'll see you all in June in Boston. So have a great night.
Thank you, everyone.
Thank you.